Good morning, everyone. It is great to see you all again for our Monday seminar. Our objective has been to understand healthy aging in all its dimensions, and the more we learn, the clearer it becomes that we cannot fully understand healthy aging or how to extend health span without looking across the entire life course. The foundations of lifelong health are laid very early, starting even before birth. Today's speaker, Dr. Aline brings that perspective. She is professor and interim section chief of development nutrition in pediatrics at the University of Arkansas for medical sciences. Aline completed her PhD in nutritional sciences at the University of Illinois and is a registered dietitian. Her research focuses on how maternal and early life nutrition influence children's growth, metabolism, and long-term development. She has led pioneering work with cohort studies and randomized trials examining how maternal weight and infant feeding shape later metabolic health and development outcomes. Aline also served on the 2025 Dietary Guidelines Advisory Committee, and her research is supported by the USDA, ARS, and several NIH institutes. The title of her talk today is Empowering Futures and Nurturing Health Through Maternal and Pediatric Nutrition and Activity. It's slightly different to the ones that you have on your screen, but the talk will be the same. So, as usual, remember to post your questions as they come to your mind in the Q&A site. And beyond that, Aline, thank you so much for joining us, and we are really looking forward to your presentation. And I'll see you on the other side.
Thank you, Jose. Thank you so much for the kind introduction. It's really a privilege to be with you today and to share some of the wonderful research that is going on at a sister center, a Human Nutrition Research Center that's located in Arkansas and in Little Rock. I did change the title a little bit because I'm going to really focus on a study that's called Beginnings and looking into longitudinal insights for early nutrition. And like Jose said, all of those stepping stones are important for the lifespan health. So while I'm here today and I have the honor to be with you, I want to take a few moments to acknowledge the outstanding contribution of many individuals and institutions without whom and which I wouldn't be here today. It takes literally a village to do some of those cohort studies, and I won't be able to name all of the contributors, but I want to acknowledge the entire group at the Arkansas Children's Nutrition Center. Their dedication and outstanding contribution to our nutrition research really have shaped and are shaping the ACNC impact on children's health. So just to provide a little bit of context, our center's research has explored how parental nutrition and 24-hour movement behavior that includes physical activity, sedentary behavior, and sleep can impact children's development and health, starting really from preconception all the way to adolescent using preclinical and clinical research studies. And you probably have heard the term of the first 1,000 days or 2,000 days, which really encompasses pregnancy and early infancy and childhood up to a certain age, depending on the 1,000 or 2,000 days. But also adolescent and pre-adolescent are a specific focus of our research. So we really span pregnancy, infancy, childhood, and adolescent. And so today I chose a study that really reflects that continuum and looking at the impact of early nutrition to share with you some of our results from the beginning studies. So I'm going to focus a little bit of time on infant formula. And our question back 20 years ago was, are infant formulas providing similar outcomes for children in terms of growth and development, and whether dairy or plant-based formulas are similar. And specifically, we were interested in the effect of soy infant-based formula. And back then, around 2008, it was about 25% of the infant formula market. It was the first choice for cow milk allergies and intolerances as an alternative to cow milk-based formula. However, the soy-based formula have phytochemicals called isoflavone, and there were a concern from preclinical data that maybe they had estrogenic effect. I wanted to give you a snapshot on where we are today with soy infant formula. It's unclear what the market share is, but it has decreased tremendously because of partially and extensively hydrolysed formula, but also because of other plant-based formula that are made with pea or rice protein. But it's still a choice for plant-based formulas, as it is still relevant. In fact, if you do a Chrome search, which I did about a couple of months ago on soy-based formula, this is what you get, which can be a little bit overwhelming. So let's just zoom in into that blue box. And you can see that actually the results are not all soy formulas. A lot of them are not, which is very confusing also to the consumers. So here are the main formulas that are really on the market that are soy-based from the major infant formula companies that you see on the shelves. The study I'm going to talk about today focused on the first two, Enfamil and Similac. We provided two different brands in case there was a preference from the parents. So let's talk a little bit about infant formula FDA registration. There is a requirement that lists what should be the nutritional adequacy, the safety testing, the manufacturer standard, labeling, and then an FDA review. And one of the requirements is a human study for registration. It needs to be an RCT, a randomized controlled trial, between the new formula and an existing marketed formula. It has to be 15 weeks minimum, so up to 4.5 months of age. It needs to be in healthy children that are less than 2 weeks old. And approximately 50 to 100 participant randomized is usually the target. And they have to be exclusively formula fed from the study initiation, so before 2 weeks of age. And one of the major criteria is that the rate of gain needs to not be different from the control formula, which is about 30 grams per day. And we could argue around this requirement because the breastfed infants may not gain as much. So are we having the right control? It's actually currently a debate, but this is currently what the FDA is requiring. So if you look at the continuum of that infancy to adolescent spectrum that I was talking about a minute ago, the FDA study length is right within infancy, right? So we're going to understand whether the infant formula is safe at those ages, but we really don't have data on its impact into childhood development or into adolescence. And so that's why the beginning study, which is one of the largest and longest clinical research study of an infant formula, was designed to understand those differences in growth and development of breastfed children compared to children who were fed a dairy-based infant formula or a soy-based infant formula. And then we follow those children at 3, 6, 9, and 12 months during infancy, and then every year until 6 years, and we just recall them at age 14. So just to give you a little bit of context, we enrolled 600 children, which was quite a large sampling. And the breastfed infants had to be breastfed, obviously, at enrollment and plan to continue breastfeeding. For the formula group, it was a choice of the parent on which formula they chose for their children. And so this is not a randomized controlled trial. It is an observational study with the parent choosing the formula. However, once they were enrolled in that group, we provided the formulas free of charge for the first full year. So we knew that all of the children remain on the study formula throughout the first year of life. For the breastfed infants, we encourage breastfeeding up to 1 year. And if the mother-child diet couldn't meet the 12 months mark, then they were weaned off to a dairy-based infant formula. So this is a beginning study. It has been going on for almost 20 years because I'm going to present data today on the 14 years. So the study focused on a lot of things. So not only was the study very long and trying to characterize a lot of the early infant feeding, it also looked at nutrition throughout those time points, growth and fitness, including body composition, biosamples, a lot of developmental outcome with brain function. We'll talk a little bit about that, as well as the reproductive organ sizes and feature, as well as the puberty, because of that potential phytoestrogen present in soy-based infant formula. So for nutrition, we use 3-day food records analyzed with the nutrient data system for research. The body composition, we use dual energy X-ray absorptiometry. And fitness was only evaluated at age 14, and we did cardiometabolic testing. For brain function, we use electroencephalogram, EEG, to measure some of the event-related potential, ERPs, but we also look at magnetic resonance imaging in those children. And all of that was paired with cognitive assessment and administered by trained technician under the supervision of a psychologist and neuropsychologist. And then the reproductive organs were measured by ultrasounds. And for the girls, we looked at breast, ovaries, uterus. And for the boys, we looked at breast, prostate, and testicles, sizes, volume, and features. And then we looked at the puberty onset and the stages. So we used Tanner stage there. All right. So let's move on to some data. And let's start with nutrition. We're a Children Nutrition Research Center, so I thought it was appropriate. We use a NDSR software from the University of Minnesota to analyze a 3-day food record. And so one of the important points that we wanted to look at was whether the infant feeding group changed when solid food was introduced, or foods that were not human milk or infant formula. And at the time of the study, the recommendation was to introduce those foods around 4 months of age. Now the recommendation is at 6 months. But you can see that there was no statistical differences between the group, and those are really going to be throughout my talk. The BF is for human milk, MF is for the cow infant formula, and SF is for the soy infant formula. So if we look at energy intake throughout the first 6 years of life, you can see that during the first 12 months, there are slight differences between the children that were fed human milk compared to formula, which is normal. We know that there are differences between the two. And also the way to assess human milk intake may not have been the best. In our study, we didn't do nurse weigh or other types of analysis that would have narrowed down that intake during the first year of life. But regardless, our interest was really between the two formulas, and you can see that they are very similar throughout the first 6 years of life. So in terms of energy, all children's pretty much were the same starting at 2 years until 6. For protein intake, it's the same concept. There is a bit of a difference between the two formulas due to the availability of the proteins as well. So just protein intake in kcal is not reflective of that. So you see a little bit of difference during the first 12 months, but not after that. In terms of fat intake, again, the first 12 months is slightly different between the human milk and the formula, but then no changes throughout the 6 years of life. And carbohydrate is similar. So you see kind of an inverse relationship with that. So we are digging into a little bit more because we know that macronutrient is not on the answers, right? We're looking at macronutrient, phenolics, fibers, and dietary patterns and how they are impacting growth and development, but there are not that many changes across the different groups. But we're still interested in looking at all of those dietary patterns on the entire cohort. So we still have work to do. So if you want to join us, please do that. We have plenty of data still to process. So in terms of growth and fitness, I'm going to present today mostly growth and body composition. We used the DEXA, which you may be familiar with, that was designed to measure osteoporosis. We can use it to measure skeletal health during infancy and childhood, but also body composition. And this is a picture of a sleeping baby on the machine, and then it scans. So it's kind of an X-ray that's a lot weaker than a chest X-ray in terms of radiation, but gives us a lot of information. And then on to your left, you have the peripheral quantitative computed tomography that we use to measure one of the bones in their arms and have a little bit more refinement into three-dimensional bone characteristics, because the DEXA is just a two-dimensional scan. So we use both technology to get results for our cohort. And so, as you can imagine, the bone mineral content, which is like the skeletal health, needs to be adjusted for height, because if you have a baby that's very long, then you may have higher bone mineral content. So this is height adjusted for the female and the males. And we really don't see much differences in terms of bone mineral content or bone mineralization throughout the first 6 years of life. We do see that by 6 years, the children that were fed soy-based infant formula during infancy have a slightly higher bone mineral content adjusted for height. But that's very small and not really clinically significant. And I'll talk to you more about the rest of the analysis we did to kind of dissect that. So at various ages, we use the PQCT plus we did some serum bone marker on a subset of the study participant to look at skeletal health into more details. And what we found is really when we look more at the three-dimensional bone structure, the cortical and the trabecular bone, and also indices of strength, there are no differences across the 3 feeding group during infancy throughout the 6 years of age. And it was similar with the serum bone marker. There's no differences in bone metabolism between the groups, whether they were fed human milk or the 2 infant formulas. So right now we're doing the analysis of the 14-year bone health. We're not seeing major differences, but we still need to finalize the models. So I'll take that with a grain of salt. So let's move on to body composition. This is Standard anthropometrics that I'm going to talk about, BMI, but also fat mass index and fat-free mass index. So we use standard anthropometric measures with standardized protocols, so it's repeated measures, and it's more accurate than a physician office. And then we compute the BMI from that, or the Z-scores from the WHO curves. And then we can also do fat mass index, which is similar to your BMI, except you take only the fat mass divided by the meter square. So it's an index of adiposity. And so if we look at weight, which is a pretty crude measure, we can see that there were some differences throughout the first 6 years of life with the children that were fed soy-based infant formula during infancy being heavier, starting at 3 years of age, compared to the breastfed infants, but not compared to the cow's milk fed infants. The body mass index is similar, and that only starts at age 2. You can see that really the top line is the children that were fed soy infant formula, and the middle line is those that were fed cow's milk-based formula, and then the bottom is the human milk fed. And so differences between the soy formula and the human milk, but not between the two formulas that were significant. When we look at the fat mass index throughout the first year, there's a little bit more of a dynamic change there. But throughout the first 6 years of life, you can see that, as expected, the human milk-fed children had a lower fat mass index up to 6 years as compared to the soy at 3 and 4 years, and as compared to the two formula at 5 and 6 years. So let's switch gear a little bit, and I'm going to tell you a little bit about brain function. Again, we used ERPs to measure brain activity based upon different paradigm that the children could either see or hear. And so we placed that net with little sponges to capture the brain electrical activity, so we can see when it is activated, but also where, right? With all of those 126, I think, sponges were on the nets that were used for the study. And then we pair that also to cognitive assessment that are usually done by psychologists or neuropsychology technician. And so there are like about 20 publications that I tried to summarize into 2 slides for you today to try to make it a little bit more digestible. But the main focus of the brain development that we looked at was based on language processing. And so we do see differences between the children that were fed human milk in the green versus the children fed soy formula in the purple, where the breastfed infants had faster encoding, stronger syllable discrimination, and earlier left hemisphere activation. And so when you think about syllable discrimination, that started really early on with those little babies having their net at 3, 6, 9, and 12 months, hearing 2 different syllables. So it was either a pa or a ba, and then they were repeated in random sequences, and then we can see the activation on the discrimination of those 2 syllables. And so for the soy-fed infants, we see what looks like a daily brain maturation with a bit of difficulty in that phonological awareness and a greater right lateralized recruitment at 12 months. It seemed like they recruit more activity to do similar tasks, is the interpretation. And then there was some finding on high frequency brain activity with the human milk children that had higher beta and gamma activity versus the soy-fed children. But those were only at certain time points, and then the results kind of normalized. And so it's really difficult to interpret such very distinct data um, at at those time points, because in the end, if we look at the developmental outcome by the feeding type, we do see that the breastfeeder had some cognitive or developmental advantages in infancy at 3 years, at 5 years, compared to both formulas. But by 6 years, we really don't see any differences anymore. So it sounds like there is a clear advantage of human milk. It's unclear that the difference in the seen with the soy formula makes it really a difference long term, at least not until age 6 in terms of the developmental testing. So now I'd like to spend a few minutes on the age 14 data that we are just writing up. So this is not published data yet. What we've done is the beginning study was really set up to look at the children from 2 months to 6 years. But then we thought that it was a great opportunity to do a follow-up at age 14, especially with the pubertal development and the questions surrounding the soy infant formula and the phytoestrogen content. And so we recall all the children's and their parents to come back at age 14, which is really neat to see those children back as grown-ups. Some even came from out of state, which was pretty amazing. Unfortunately, because there were so many years between the 6 years and the 14 years, we did have quite a bit of loss to follow up for people moving, or we couldn't even contact them and couldn't come to our study visits. That said, we ended up with more than 150 children that attended the 14 years visit, and you can see the split here, about 76 breastfeeder, 62 that were fed cow's milk infant formula as infants, and then 52 that were fed soy-based infant formula. And I'm presenting here a little bit of the aggregate on all of the data so that you get a quick snapshot, since there are a lot of data. Their mean weight was similar across the group. Their height as well, weight circumference, was similar. And the BMI, the fat mass index and the fat-free mass index were not significantly different, although there were quite a bit of variability on the cow's milk group on the fat mass index. So there are no statistical significance at 14 years between those groups. You can see there is a numerical increase in BMI in the soy-fed group compared to the breastfed group, which has been shown previously in the literature. What we were really interested in is whether those two formulas were similar in growth and body composition. So right now, we're trying to actually model those trajectories of weight and body composition throughout the 14 years to see if there are differences that we don't really capture, but looking at distinct period of time and ages. So more on that soon. The other thing that we looked at age 14 that we were really interested in is metabolic syndrome. That's defined as a waist circumference greater than the 90th percentile for age, sex, and race, blood pressure greater than the 90th percentile for age, sex, and height, and then triglyceride above 110 milligram per deciliter, HDL below 40 milligram per deciliter, and glucose greater or equal to 100 milligram per deciliter. So if a child had 3 of those abnormalities and they had metabolic syndrome, and if they didn't, then they're listed without. And you can see the differences here across the groups. We had more metabolic syndrome in the children that were fed cow's milk formula compared to breastfed, and the soy fed were in between the two groups. When we looked at to try to dissect a little bit more from that metabolic syndrome, we looked at systolic and diastolic blood pressure, trying to think about hypertension risk, and we really didn't see any differences across the groups here either. And I'm not going to go through a lot of the data because it will be a lot of graphs, but at age 14, we collected blood from those children and we looked at sugar metabolism. So your glucose, fasted insulin, insulin resistant, and leptin. For the fat metabolism, we look at cholesterol, HDL, LDL, and triglyceride, which helped us also compute the metabolic syndrome. And then we were also interested in inflammatory markers. So we looked at C-reactive protein, interferon gamma, TNF-alpha, tumor necrosis factor, and interleukin 6 and 8. And across all of those metabolic marker, glucose metabolism, lipid profile, and inflammation, we found no significant differences for the children at age 14 from their early infant feeding group. And right now we're modeling that data with their dietary intake at age 14 and then their physical activity at age 14. And we still see no significant difference. So even after adjusting for a potential confounder, we don't see any differences. All right, so let's spend a little bit of time on the reproductive organ question, which was very central to the beginning study because of the phytochemicals that are present in the soy infant formula called isoflavones. And so to be able to really answer that question, we looked at the reproductive organ of ovaries and uteri for the girls as well as the breast when they were young, and then testicular, prostate, and breasts in boys throughout. And so I'm going to go through more on a girls versus boys manner. 6 differences are there. So we're going to start with the boys. And we did ultrasounds on those boys at 4 months, 5 years, and 14 years. And the only difference we could see was the testis volume at 4 months. That was greater in the infants who were fed human milk compared to the infants who were fed soy formula, infant formula. Both formulas were the same. So we have a difference there, and that was during the exclusive infant feeding period, right? They were only eating either their formula or their human milk. However, about 5 years and at 14 years and at 4 months as well for breast and prostate, there was no other differences, whether it was on the size, the volume of the characteristics. So characteristics could be, for example, for the testes, whether they were descended or not. And so you can see that the slides summarize a lot of data on really a continuum of aging using exactly the same technology to assess the organs and also the same radiologist. So Dr. Mary Beth Moore here at Arkansas Children's has been a wonderful collaborator to generate all of those data. So in terms of the girls, the ovarian volume for the girls at 4 months were different. And the difference was that they were greater for the girls that were fed cow's milk formula versus the breastfed or the ones that were fed soy infant formula. And so again, that's one difference in the measurement that we did at 4 months for the girls. However, we looked at breast volume at 4 and 5 years, and then we looked at uterine volume and ovarian volume at 4, 5, and 14 years, and there were no differences. We also looked at the number of cysts in the ovaries. We looked at the uterine shape, and there were no difference on all of those parameters. And so we're actually writing the 14-year manuscripts right now to report all of that. As you can expect, at age 14, we couldn't really analyze the breast volume of the girls because the development there may be more defined by their genetics and their pubertal status. So it was only done in the boys. All right, so let's go into the pubertal stage. So puberty is assessed using the Tanner stages. It classifies the physical development during puberty based upon external characteristics such as breast and genital development, pubic hair growth. And you can see here that there were no differences between the group, whether it was in the girls or in the boys in their Tanner stage when they came for their study visit at 14 years. And then if we looked at the distribution, so you have different stages for Tanner, and here we have 2 to 4 in the main categories, and then stage 5 in the lighter color for each of the feeding group and each of the sexes. And there weren't really no difference between the ratio of 2 to 4 Tanner versus 5 across all of the groups that we looked at. One of the big questions for the study was surrounding the age of menarche. Because again of the isoflavin present in the soy infant formulas. And from our data here in the cohort in Arkansas, we didn't see any differences in the age of menarche, which is the onset of their first menstrual period. And the mean age was approximately 12 years across, and really didn't differ across the groups. One of the things that we've learned throughout all of that reproductive organ assessment is that it is actually quite challenging to image some of those organs. And especially in boys, we had a lot of refusal rate for the testis and the prostate, but especially for the testis volume. So since this was a follow-up study, everybody that participated in the beginnings, we tried to recruit, and they did all of the portion of the study that they agreed to, but that was one of our limitation, and it would be a limitation when we publish the results because of the number of kiddos that agreed to do some of those parts. So I want to give enough time for questions, so I'm going to try to summarize what I've been talking about for the past 40 minutes. First of all, it's the results of years of data collection and analysis from a lot of different investigators and team members who either have put those children to sleep for the DEXA assessment during infancy or have helped them through their blood draws at age 14. We have an outstanding team helping us conduct those very large cohort study in a longitudinal fashion. But in summary, I hope that I've shown you that really the dairy-based infant formula and soy-based infant formula during the first year of life lead to similar outcomes for growth development, but also puberty. We really don't see differences between the formulas. All of the differences that I have shown you are differences between the breastfed groups or a formula-fed group. And we know that there is advantages of human milk for cognitive development and growth. And that's what our study has also shown. But those advantages are rather small. And so when we think about even cognitive advantages on an IQ scale, we're talking about 1 to 2 points. So clinically, it's not like they are advanced or delayed per se for those children, but there is a slight advantage. And it is true for immune development, although we haven't looked at the immune development in this study per se. The differences was in language development. That was different between the soy-fed infants who scored lower during the first year of life in infancy than breastfed infants. But then as they grow, the result seems to kind of normalize for both. So for us, this was a major study. It provides critical information, not only on what infant formula to choose, but also on understanding the health impact of human milk. So we're looking at both sides of the coin. I think it's important for mothers who cannot breastfeed or choose not to breastfeed to feel reassured that whatever they choose in terms of infant formula yield to similar growth and development for their children. And so I'm going to stop here and thank you for your attention. Wanted to give you a little piece of Arkansas. This is from our Petit Jean State Park. It's a beautiful area of Arkansas. It is called the natural state for a good reason. So if you're ever out for a visit, please stop by. Love to chat. And if you have any question that needs more follow-up than we have time for, I think we have about 15 minutes. Here is my email address as well. So thank you so much.
Thank you, Aline. That was truly excellent. And listening to your talk, I couldn't help but think about of how we tracked hurricanes. When they first appear, they are not hurricanes yet, just small disturbances forming somewhere out of the coast of Africa. From that moment, we spent days trying to predict their trajectory and strength, drawing those familiar forecast funnels or cones like Hurricane Melissa today. Sometimes the path is easy to anticipate, other times it's full of surprises. What your research shows us is that human development works much the same way. The conditions in early life, even before birth, influence the course of health decades later. And our ability to understand and anticipate those early patterns determine how well we can prepare for or prevent what happens in later life. So thank you, Aline, for helping us see that connection so clearly and for reminding us that to extend health span, we need to start much earlier when the storm has not yet formed.
Yes, and also that we have to follow up longer, right? So we have a group of people interested in trying to follow up that cohort a longer time as well, because maybe some of those very early differences may be important later in life. We just don't know. But up to 14 years, we haven't seen major differences.
Yeah. Okay, with that, let's open the floor for questions and discussion. And I am sure that there are Many thoughts and ideas linking your work to our efforts in healthy aging. But before we get into the questions, I have to ask, how do you keep babies so quiet and still for the DEXA scans? That must take some magic, right?
Yeah, it takes magic. It takes very patient team members and parents. So we put the babies to sleep. And so they sleep during the DEXA scan. So it takes a few trial, but we've had a good rate of success. It's a lot easier when they are at age 14, to be honest.
Okay. Well, from Nirupa, do you think differences in background diet quality in later childhood may help explain why the early differences between breastfed and formula-fed groups were not longer evident at 6 years?
Yeah, that's an excellent question and an excellent point, right? We've characterized very carefully their nutrition intake during the first year of life, but we cannot not consider what they've been eating from age 2 to 14, but also their physical activity, their environment, their household cohesion. We had a few studies looking even at that, like how does that impact the children long term? You could talk about screen time from brain development as well. So I think a lot of things come into play for later on development. And so you're right that the first year of life is really important in setting up some of those developmental trajectories, and the sustained nutrition and physical activity and enrichment throughout their childhood is also going to have a very important impact. And so that's where we are getting a little bit of a difficulty to dissect at age 14, how much is that the infancy impact versus the 2 to 14 years impact. And that's why it's really important to model for their nutrient intake throughout that period, but also physical activity. And we have some measure of enrichment as well in cognitive development, but also their surrounding family structure. But it is difficult. It just goes back to the programming and how can you map that out so carefully. So thank you for the question.
Yeah. Well, it's not the first time that we are confronted with results like yours, right? That we say, oh my goodness, everything looks the same. So how we can continue preaching the things that we do if it doesn't matter, right?
Yeah, and that's that's been a very difficult thing. First of all, publishing negative results in the literature is challenging, right, for all of us. So that has been a great challenge to always say there's no difference. And also for the funders, right? I mean, you keep asking for money to say that really there's no differences, but I think that study was so important from a reproductive standpoint and the phytoestrogen question, that getting them to 14 years was key for us to answer that question.
Yeah. However, continuing with what seems to be a failure of our experiments in inducing significant changes, what we did was to go deeper, because after all, many of those variables are kind of on the surface, right? And you are in a privileged place to go deeper. And I am talking obviously about metabolomics. It's when we go to that level that then we can start differences that they have not time, opportunity, or need to go to the surface to
Yeah.
express the differences. So that's something that I guess is part of what you were saying before. You have there plenty of data in the queue to be analyzed in terms of metabolomics, in terms
Yeah. And that's an excellent point. And one of our other study, which is another cohort that we're bringing children up to age 14, but we have pregnancy data, we have their placenta, we have a lot more information on their human milk intake, and we have blood and stool and urine throughout their childhood, because for beginnings, it was 20 years ago, so we weren't really thinking about metabolomics at the time. And so on other cohorts, we can do that better for the programming piece. So we can bring metabolomics, microbiome, we can bring all of those phenotypes that we do well, even resting energy expenditure or sleeping energy expenditure if they are too young to do resting. But we have all of those measures to integrate and understand better what is the true programming. And in some of those studies, it was not based upon necessarily infant feeding, but the maternal health. But I think we can get to the same answer. The problem we're faced today, which we just had a meeting last week about, is how do you integrate so many different level of data that are so high dimensional. So the nutrition data itself is very high dimensional if you think about integrating phenolics and other data, but then the omics, the microbiome, the placenta. For the placenta, we have RNA-seq, we have metabolomics, we have epigenetics. So we have all of those bits of stories throughout. What we're really interested in is how do you bring that together? And we're getting there, but it's a slow getting there.
Well, again, you are mirroring our own problems with that difficulty in integrating and trying to get again to the bottom of the problem, right? And to prepare the data for those kind of analysis that obviously come with artificial intelligence is not trivial. And there are no funding in the original grants in order to take over that difficult task. So yeah, I mean, we'll have to just wait to we are able to do it. Now, in terms of additional questions, even though you may not be able to see it from your data, you are still an expert in the field, you know what is going on, other people didn't find the same, why, who knows. In your experience or knowledge, which early life windows seem more critical for that lifelong metabolic health?
That's a great question. There is some pretty interesting data that says that even the metabolic health of the dad is very important for the long-term programming of the child. So when we think about windows, it's almost even preconception that you would have to start to think through. But I think every window could be important. And that was the question before, right? Like you can maybe offset some of those hits early on by other healthy behavior later on. I think the big question is maybe not the window, but how many hits for each window do we take, right? So like if we start with a poor environment early on, whether it's metabolic or cognitive environment, and then we keep having hits as we develop and grow, even through adulthood, then I think it's a number of those elements that are going to yield to a lifelong and healthy body versus healthy body. So I think there's a lot of potential for us to rescue and intervene, but it really is within all of those windows. But then the addition of all of that. But this is all my speculation. I have no data to back this up.
Well, it's your speculation, and it's also the cumulative research, body of research that is being done. We have some data sets like those in the UK that have been following people from the very beginning, right? Even, well, very beginning, including the mothers, right?
Yes.
Before the babies were born. So, well, I hope sometimes we get it right.
So when we think about, pregnant, and all of our work is surrounding pregnancy, early infancy, but also preconception. But I think there is, and just with your work in aging, right, there is always an opportunity to get healthier at any stages. So even if a woman enter pregnancy with excess weight, I wish we could have more data to tell her, well, if you walk that many steps and eat healthier, then you would have better outcome for you and your baby. But the same as we age, right, where we get more into precision nutrition and lifestyle, where we can actually adjust to respond to those potential hit that we've been through in life.
And that brings the following question you practically answered. What are the biggest barriers to translating early life nutrition research into the real world practice?
Yeah, well, there are a lot, right? I'm sure you're faced with the same later on. A lot of the translation is uptake. So we may have evidence base, but implementation of it in practice takes years between, maybe we have the clinical trial with the data, but then when it gets to community or even care, there's a big lag. So I think trying to use implementation science to reduce that gap would be one of the things that could help us advance faster. But then we're faced here in Arkansas with quite a bit of food insecurity. 1 in 4 children are food insecure here in our state, and that's 25% of our population, right? So, I mean, that brings a different dimension of how do we provide nutrition security, not just food, to all of those children so that they can have a healthy life later on. But that is very complex because we get into an environment of high stress, housing insecurity as well. So it's compounded into a lot of other stressors that can be difficult to address. And then if you are not even within that spectrum, we know that behavior change is very difficult. And so starting early has been shown to be great. So there are new data that was put by the dietary guidelines or highlighted in the dietary guidelines that exposing children to a lot of different foods and repeated exposure over time can really help. Seems to help even in childhood, so not just in infancy. So there are things that we can do and that we could do even in our school system that could help a lot.
Thank you. And this is the bonus question and the last question.
Okay.
How might collaboration between developmental and aging researchers help close the loop between early nutrition and extended health span?
Yeah. I mean, there's a lot, right? Just talk about skeletal health and optimizing that peak bone mass so that in aging, we don't have all of those potential issues with osteoporosis. There is a lot that link both of our fields. I think we need to talk more and we need to collaborate more to make sure that we're answering what the consumers, which is all Americans really want, is to be healthy.
Yeah. Well, with that key word that you use, collaboration, we can close your lecture. Thank
Great.
you again. It was great, and the hope is that we will continue interacting towards that last goal. Thank you so
Yeah,
much, Aline.
I would love that. Thank you so much for inviting me. It's been a pleasure.